Hello all. Today we'll talk about chronic bacterial meningitis. So acute is something which we all know about. So today we'll talk about chronic bacterial meningitis. So when we call it as a chronic meningitis is when there is a signs and symptoms of meningitis which is more than uh, 4 weeks, lasting for more than 4 weeks. So when does this happen or when does this meningitis become chronic is if the acute meningitis has not been treated properly, or rather I would say the treatment protocol has somehow not managed to eliminate the bacteria completely, or bacteria are more resistant to the treatment given, or the infection is from adjacent structures like your parameningeal, what we call like otitis media. Mycobacterium tuberculosis is one very important factor in most of the chronic conditions, especially in India. You have this Borrelia species, which causes Lyme's disease that can also cause chronic meningitis. In olden days, the syphilis or Treponema pallidum, in the tertiary part of syphilis, there is a neurological manifestation also. Very rarely, some factors like nocardia, actomyces, all those things can also cause chronic meningitis. So, clinical picture would somewhat be like patient has a persistent headache or neck stiffness, which is normally seen in your acute meningitis also. And sometimes the because of the accumulation of CSF, they can be hydrocephalus. Some of the pressure effects can lead to facial weakness or double vision, or some kind of hearing loss, optic atrophy, all those things because of the pressure effects on the nerves. Sometimes there can be a radiculopathy, which is basically depends on which area of the nerve is getting, uh, the pressure, the effect is there. Okay. Sometimes there can be also some changes like drowsiness, disorientation, or memory loss can also be seen there. Okay. So tuberculosis, when we talk about it, was one of the major things. So that is basically 5% of the extrapulmonary tuberculosis patients can end up with the tuberculosis in the central nervous system. It's most commonly seen in children, but can also be seen in adults. And in now the present condition, patients living with HIV can also manifest with tuberculosis of the CNS. So in the CNS, there are two main forms. One is a tubercular meningitis and tuberculoma. So tubercular meningitis, again, it can spread via the blood as a part of the routine pathogenesis, or it can be because of the post-primary tuberculosis. And the disease will evolve around 1 to 2 weeks, or it can take more time as well. Signs and symptoms will be similar to tuberculosis as well as the meningitis. That is, patient will have headache, some mental changes, some low-grade fever, anorexia, irritability. Sometimes it can slowly progress into confusion, altered sensorium. Mostly the cranial nerves, the ocular nerves are affected. If there is a formation of emboli, they can lead to stroke, because of the blockage of the cerebral arteries, and if untreated, can progress towards coma with hydrocephalus and intracranial hypertension. So this is a CSF comparison. If you look at it, the as far as tuberculosis is concerned, the CSF pressure is slightly elevated with little bit of higher number of leukocytes, and predominantly it is made up of the lymphocytes compared to the neutrophils which we see in the acute meningitis. Glucose is slightly decreased, and as well as the proteins are mildly or moderately or severely increased in tubercular meningitis. For diagnosis wise, you have the main thing is CSF analysis, where you are going to see more of a lymphocyte counts. Protein will be increased, the glucose concentration. Along with that, laboratory wise, you can just keep the CSF in a test tube outside at room temperature. It can form a cobweb, which is because of the high fibrin content, which is one of the uh, classical ways to determine whether this patient is having a tubercular meningitis. You can also do acid fast stain, where you will see the acid fast bacilli. Now, culture wise, it is the gold standard method of diagnosis. Only thing is it takes a bit more time, around 4 to 8 weeks on LJ medium. So, maybe to faster technique would be the mycobacterial growth indicator tube, or you can go for a gene expert, which is automated real time PCR, and you can also look for the imaging for the typical changes in tubercular meningitis. So on your left is your cobweb formation because of the high fibrin content. On the extreme right, you see the colonies on LJ medium. So this is the picture you are going to see in the imaging studies. And treatment wise, obviously it has to be immediately initiated, and even if the immediate test results are negative and it points to the clinically points to tuberculosis, it's better to do a proper diagnostic follow-up workup and then start the patient on antitubercular therapy. You can also add steroids to reduce the inflammation and CSF pressure, so that will allow faster resolution of the disease. The next thing is a tuberculoma, which is an uncommon manifestation, but it will be there. It presents as a space occupying lesion, so it has to be differentiated from malignancy, which you can do it either using a CT or MRI. So this is one of the representative pictures for the formation of tuberculoma in the brain. So next thing is about neuroborreliosis or the Lyme's disease, which is caused by Borrelia burgdorferi, transmitted by the bite of a tick. So along with the cutaneous and lesions and the joint pains, the patient can also have some CNS infections, which can be a meningitis, the cranial neuritis, and palsy, and as well as radiculoneuropathy. And when you look at the CSF picture, it will be elevated lymphocytes, elevated protein levels, and normal or slightly low glucose values. Now, when the meningopolyneuritis is concerned, there is a pain along with the CSF cell count increase without much of a meningeal involvement, or it is not very clinically, it is not very clear. So that is called as a Barnwart syndrome. Now this will completely resolve in a month, but sometimes it can stay chronic and can present as a proper chronic meningitis at a later stage. So treatment wise, it is ceftriaxone for 14 to 28 days long course, or you can also give cefotaxime or penicillin G. Next is the manifestation of syphilis in the CNS. It is a tertiary syphilis, a very small percentage of patients. As you know, syphilis is a sexually transmitted disease that can also invade the CNS and can be asymptomatic for a long time and can present later on as a neurosyphilis uh, morphology. So clinically, the patient can either have an asymptomatic or can have a meningeal type or meningovascular or general paralysis of the insane or tabes dorsalis. So again, here when you look at the CSF, there is an increase in the lymphocyte count and protein levels. You can do VDRL testing with the CSF. You can't do RPR with CSF. So basically, you can use this test as a screening test, which can be followed by your fluorescent troponomal antibody absorption testing or PCR based testing. Treatment wise, crystalline or cocaine penicillin for 10 to 14 days. And if the titers don't come down, you might have to continue the treatment or go for a retreatment. If ideally, they say that if the patient is allergic to penicillin, you can try desensitization, and how much of it is actually successful, we don't. So the next part is about the viral causes of meningitis, and most commonly it is the enteroviruses which are the important cause of viral meningitis, or what you call as a aseptic meningitis or atypical meningitis. So apart from the enteroviruses, you have a lot of this herpes viruses, herpes group, that is your herpes simplex, varicella zoster, Epstein-Barr virus, and others. You have the arbovirus. If arbovirus, you have two types. You have hemorrhagic type and you have the encephalitis group. So encephalitis group can also cause this kind of a chronic meningitis. Then you have the lymphocytic choriomeningitis virus, which is more common in patients who are in contact with rodents. Okay, and rarely patients with mumps, measles, influenza, or HIV patients can also present with the chronic meningitis features. So, who are at risk? People at any age, but most commonly children at the extremes of age, like children less than 5 years and old age, immunocompromised patients, or patients who are on chemotherapy or transplant recipients, or patients living with infected patients in close contact. And most of the times, the time when these arboviruses and enteroviruses are more common, that is when the infection also starts to manifest as chronic meningitis. So clinically, patients will have fever, headache, stiffness in the neck, photophobia, uh, either drowsy or difficult to wake up from sleep, nausea, vomiting, irritability, lack of appetite, and lethargy. So treatment-wise, uh, we have a symptomatic kind of a treatment, and diagnosis wise, you have a CSF analysis, and molecular methods is much better if you are thinking of a viral etiology. Viral culture can be done, or antibody detection can be done. Okay, and if the treatment part, first thing is the symptomatic treatment. Second thing is, if you are suspecting meningitis with herpes virus, acyclovir can be a good choice, and patients with HIV can go in for a proper uh, antiretroviral therapy, which is highly active antiretroviral therapy. So enterovirus, when you see there is, we are going to first talk about the non-polio enteroviruses, which is a very common reason for viral meningitis. Uh, these cases can be either in a small population, not exactly to be termed as an endemic or epidemic. So the most common examples are the Coxsackie virus, echovirus, paracovirus, and enterovirus 71. Now these pathogens can spread via the fecal-oral route. They'll multiply in the intestine and they can go into different areas and cause clinical symptoms. Now, if you look at the overall picture, you have the Coxsackie virus, which can be divided into Coxsackie A and B, depending on the reaction with growing on suckling mice. So, Coxsackie A, you have 24 serotypes, barring the 15, 18, and 23. Coxsackie B, you have 6 serotypes. The name is based on the area where they were first discovered. That's in the Coxsackie village in US. So this virus mostly causes what is called as a aseptic meningitis. You have the echovirus group, which is 23 serotypes are there, so they can cause aseptic meningitis, encephalitis, rashes, common cold, or ocular disease. Paracovirus, you have 16 serotypes. Again, it can cause the same. You have the aseptic meningitis, respiratory and neonatal diseases. Now, this virus, among the 16, the serotype 1 is now reclassified into echovirus 22, and serotype 2 is classified as echovirus 23. There are enteroviruses 71, 68, and 70. So these viruses basically are reason for the encephalitis, hand, foot, and mouth disease, herpangina, pneumonia, and acute hemorrhagic conjunctivitis. Enterovirus 72 can also cause infection, but now it has been classified as hepatitis C. You have a rhinovirus, which is one of the most common reasons for this common cold, and there are more than 100 different serotypes. So clinically, the Coxsackie virus can spread through the infected person's nasal and throat secretions, and they will produce different types of illnesses. Incubation period can range around 1 week, around 2 to 9 days. They can cause aseptic meningitis, herpangina, hand, foot, and mouth disease, pleurodynia, or cardiac myocarditis and pericarditis. And in a Milder version, it can be associated with common colds. They can also cause acute hemorrhagic conjunctivitis and generalized disease in the infants, and sometimes pancreatitis leading to juvenile diabetes mellitus. Diagnosis wise, you can take a throat swab, stool, or CSF samples. The virus can be isolated in an intracerebral inoculation of suckling mice. Coxsackie A will produce a flaccid paralysis, whereas Coxsackie B can produce spastic paralysis. And this virus can be differentiated on the cytopathic effect, which will be observed within 5 to 14 days. The PCR can also target specific genes, which is the BP1, which is quite sensitive and we easily be able to identify the particular serotype. You can also do detect the neutralizing antibodies to find out the presence of virus. Now we have the herpes viruses. So you know that just the rare causes are cytomegalovirus and herpes virus 6, whereas the most common ones, the herpes simplex virus, varicella zoster, and Epstein-Barr virus. Now, herpes simplex virus, second most common cause of viral meningitis, and most commonly affects the adults, and HSV2 is more common to cause meningitis compared to HSV1. Okay. So these viruses, apart from the normal neurological manifestations, it can also cause Bell's palsy, autonomous system involvement, transverse myelitis, Guillain-Barré syndrome, peripheral nerve system involvement, varicella meningitis, and Epstein-Barr virus meningitis. Arbovirus, you have different types of arboviruses. Basically, the meningitis group, the most common ones which are causing infection are the West Nile virus, St. Louis encephalitis virus, tick-borne encephalitis, and California encephalitis virus. And coming to HIV, it's one of the reasons for meningitis, around 5 to 10% of patients, and most commonly involves the cranial nerves 5, 7, or 8, which is more common in HIV meningitis. Other rare causes can have mumps, mostly causes peritonitis, and the meningitis can be a secondary component in this particular infection. We have the lymphocytic choriomeningitis virus, which affects people with history of contact with uh, rats or living conditions, right? Okay. So next we'll talk about the viral myelitis, which is the poliomyelitis. So myelitis is something where there is an inflammation of the spinal cord. Basically, there is a disruption of the signals going from the brain to the rest of the body, which is carried by these particular nerves. So while poliovirus is generally most common or most infective in childhood period, there's a very simple, small, round, spherical icosahedral symmetry virus. They don't have an envelope, and the capsid is composed of 60 subunits, which contains the viral proteins VP1 to VP4, which can be used for the purpose of diagnosis as well as for the purpose of vaccine production. It has a single sense or positive sense RNA, and there are different types. You have the wild virus, which is of three types, and you have the vaccine-derived poliomyelitis or poliovirus. So this particular strains, the three wild strains, are similar the clinical syndromes they cause, and they are slightly different immunologically in the VP1 region. And the antibody to one particular type of virus will not protect against the other viruses. Okay. Now, currently, it is said that both the type 2 and type 3 have been globally eradicated, but the type 1 is, which is now responsible for the natural disease which happens in polio. Risk factors will be again the older children and adults, pregnant women, uh, people who have a heavy muscular exercise, people undergoing trauma at the time of the CNS symptoms, tonsillectomy predisposing to bulbar poliomyelitis, and IM injections will also increase the risk of paralysis involved with the limbs. So what happens here? First, there is a the virus spreads via fecal-oral route, which goes to the intestinal epithelial cells. There it multiplies and goes into the lymphatic tissues. So wherever the tonsils, spare patches, all those things, the virus will go and settle down. and from there the lymph nodes are also involved. From once the regional lymph nodes are involved, they'll slowly start spilling into the bloodstream. So that is called as a primary viremia or minor viremia. Then they'll multiply in the reticuloendothelial system. And once the multiplication has happened in enough numbers, it will now spread again into the bloodstream, which is called as a major viremia. From there, it will enter the spinal cord, and via the spinal cord, they can reach the brain. Once they reach there, they multiply in the neurons and they will slowly destroy them. What leads to formation of Nissls bodies, which is uh, useful to find out the effect on the central nervous system and mostly affects the anterior horns of the spinal cord, leading to what is called as a flaccid paralysis. Yeah. So clinically, what happens? You have most of the infection is an inapparent infection, means it does not really come out as a clinical presentation. Only 5 to 10% is a clinical infection. So the incubation period can range anywhere between 4 days to 4 weeks. It starts with the primary viremia, which is fever, headache, sore throat, and some amount of tiredness. So most of the patients, it can stop with that particular symptoms itself. So it's called as a abortive poliomyelitis. In others, around 3 to 4 days later, the patient can go in for a biphasic fever and headache. So that is called as a major illness. And some patients can also develop stiff neck, which is a uh, marker that it has already invaded the sea. Even in the uh, illness, sometimes it can stop with this aseptic meningitis or what is called as a non-paralytic poliomyelitis. But if at all the infection spreads further, it can lead to flaccid paralysis, where it starts from the as a focal area of paralysis and slowly spreads from the spinal, bulbar, and bulbospinal regions. So mortality because of the respiratory failure can be around 5 to 10%, and slowly the recovery starts around 4 to 8 weeks and slowly completes around 6 months. And the clinical features or the amount of abnormalities in the musculoskeletal system will depend on the amount of nerves which have been damaged. So the this descending paralysis. So proximal muscles are affected earlier than the distal muscles. So it starts from the hip and spreads towards the extremities. And the biphasic part in children, whether there is a aseptic meningitis, there is a recovery, and again the return of fever, the paralytic features in 1 to 2 days. The cranial involvement will be there, but sensory part is intact and it's not affected in polio. So this is the picture of the typical lesions or typical areas where the muscular contracture is more eminent. Now, diagnosis wise, you can do a virus isolation in the primary monkey kidney cell lines using the throat swab, rectal swab, or stool samples, or you can also do a antibody detection. Now, the to prevent polio, there is a uh, national immunization schedule which contains uh, all the three viruses, inactivated viruses, which is given to children. Zero dose at birth. First, second, and third dose are given around 6th, 10th, and 14th week, and booster dose at 16 to 24 months. Now, there's a difference. There is a injectable polio vaccine as well as a oral polio vaccine. Injectable is relatively safer compared to the oral polio vaccine. Efficacy of both, that is oral polio vaccine, is much better, around 90 to 100%, and it is also economical, and that is being followed by the uh, government of India. Now, difference wise, this injectable polio vaccine will need a booster dose very periodically, and in times of epidemics, it can also precipitate paralysis. The injectable polio vaccine does not provide any kind of herd immunity. Uh, so, obviously, the cost of vaccination of the population is increased. It can prevent paralysis, but it cannot result in a intestinal reinfection. And the advantages, injectable polio vaccine, uh, there is absolutely no chance of developing vaccine in associated poliomyelitis or poliovirus, whereas oral polio vaccines need a proper cold chain to be maintained, and there is a chance of these viruses becoming active and causing the vaccine-induced poliomyelitis. Now, what is that? It is basically all the cases of paralytic poliomyelitis followed by administration of oral polio vaccine. The isolate will be somewhat similar compared to the wild virus, and it's a very small percentage of strains can become uh, rogue and cause infection. Okay. And it is not exactly capable of circulating in the community, so the outbreaks will not be risk. And most probably, the amount of infection of this vaccine-induced associated poliomyelitis is around 1 per 2.7 million cases. Okay. And how this happens is basically live attenuated vaccine strains can undergo genetic changes to become vaccine. Yeah. So the vaccine-derived poliovirus is basically capable of producing poliomyelitis. You have three different types. You have the circulating virus, which is basically circulating in the community, spreading from person to person. You have the immunodeficiency associated virus, ambiguous viruses. Okay. So the most commonly, it is the circulating viruses which are a reason for this vaccine associated paralytic poliomyelitis, and most commonly it's because of the type 2 virus compared to type 1. So eradication is on a full scale in different parts. So the basic component is the global immunization of children with polio vaccine, and this was initiated in 1995 to 96, and generally around two doses of vaccination are given in the winter season for all children below 5 years of age, and there can be some extra doses also. Plus, secondly, there is a acute flaccid paralysis surveillance. Now, the countries based on the classify the countries based on the polio transmission status. So you have the countries, endemic countries, outbreak countries at risk, as well as polio-free countries. The basic strategy is first one is to eradicate, so interrupt the transmission of all types of wild polio viruses. Second one is to strengthen the immune system and health systems to basically achieve this goal and prepare for any kind of outbreak and emergencies. And third part is to certify the countries for any kind of eradication of the wild polio viruses and contain all polio viruses, including the virus is stored in the laboratory as well. So that is a basic overview of the chronic meningitis, atypical meningitis, and the myelitis, which is mainly caused by polioviruses. I hope this overview was useful. Kindly let me know in the comments if anything else to be added. Thank you.